Well, I'm trained as a physician scientist, and when I saw patients with the chronic illnesses that I did, many of them considered themselves to have Lyme disease. I looked at the testing that was available and realized it was extremely inadequate, and therefore we couldn't be really clear about what they had. And of the major infections and co-infections, the testing seemed to be in the worst situation for Bartonella. And that's what got me into looking more closely at Bartonella. So I found the best available clinical tests, which I tested and found they were completely useless. They didn't report any positives. And then I contacted the best Bartonella researcher I knew, who was professor at Breitschwerdt at NC State School of Veterinary Medicine. He's a veterinary internist. And we developed a wonderful partnership in what we call a One Health kind of arrangement, where MDs partnering with veterinarians can do better than they can individually. So he started testing my patients. He called me one day and said, I have found that over 20% of your patients are positive, and that's more than we've seen in any other patient group, including high-risk veterinarians. And so then I kept sending specimens to him. We sent a total of 296 patients over a few years, over 2 years beginning in 2007. And that led to a paper we published in the journal Emerging Infectious Disease, where we summarized our findings and found that up to 62% or so of the patients had some significant proof or evidence on lab testing for Bartonella. These patients had some of them had failed Lyme treatment. Many of them had no diagnosis. They often had psychiatric or neurological diagnoses. And when we found that such a high percentage of them had Bartonella, it was really quite surprising, because none of their other Lyme tests were actually as strongly positive. They call Bartonella co-infection of Lyme. I now see it a little differently. I think that the Bartonella is more prevalent. And while Lyme is a big problem, Borrelia, meaning Lyme equals Borrelia, I think that the Bartonella is a much bigger public health problem overall, because there are more ways to get Bartonella than even Borrelia, including other insects, fleas, and cats. And most people have had, at some point, exposure to a cat in their life. If a cat goes indoor and outdoor, it almost always picks up Bartonella. And then they bring it indoors, and if you get a little bite or a scratch, you can get Bartonella. So it's they find a high rate of Bartonella in patients who own cats. And some people have an expression in the United States that the cat lady is a little bit odd. And now we know why, because it could be from Bartonella. So I think Bartonella is in a way, it's a separate, but there's a lot of overlap with Lyme, because the ticks can also transmit Bartonella. That hasn't been 100% proven, but we strongly suspect that they can, and they do, because we find Bartonella in deer ticks. One study in New Jersey found 1/3 of the ticks had Bartonella, 1/3 had Borrelia, and they also carry Babesia too. So there are germs in the environment. The insects carry the germs just like all the other animals, wild animals, rodents. And the more you get exposed to these things, the more likely it is you pick up more infections. And so it's great to be in nature, but being in nature also means being with the microbes. And so I think that the risks are there, and they're polymicrobial. So we have to stop thinking about these as single germs. We have to think of each germ we know about as representative of a broader group of germs. And we need to start looking at what we call a microbiome. In other words, look at all the germs, and then do the genomic sequence, look at the person's genomic sequence, and then see if, through some data analysis done by information specialists, not even medically trained, that we can see the correlations between your genes and the germ genes. So as of this year, you can probably get your whole genome sequenced as a human for about $1,000. And it used to be millions of dollars, 10 years ago. So DNA sequencing is going to produce so much data that we're going to have major data overload. We'll be spending years just trying to find better ways of looking at the data. But then if you take the microbiome, all the microbes, the human genome, and then you put this together in an analytical framework using what we call big data and big data analysis, we can start seeing correlations and mapping disease patterns much more easily than even interviewing or even doing a clinical exam. But the hard thing would be to correlate all of that massive amount of information with real results. So the validity question of the data will be a very big question for a long time to come. So that's the way it's evolving. But for now, we're just trying to make some sense out of how the different parts are interrelated. And we're realizing that when we talk about Lyme disease, it's really a much bigger set of microbes. Mm-hmm. And the public refers to all of that as Lyme disease, but that confuses definitions and it creates controversy because the medical definitions are very narrow. The public definition is a social networking definition. And so even patients who are told they have Bartonella will still call it, when they tell their friends, they'll say they have Lyme disease. You know, for example, NorVect is named after vectors, right? ILADS is Lyme and associated diseases. So, and these groups started very narrow with Borrelia, and now they're broadening their view. And I think that in general, the medical community is seeing this too. For example, we know now, and it's scientifically established, that arteriosclerosis is due to chronic infections in the vascular system. Some of that will turn out to be Bartonella, some of it will turn out to be other germs. Some of it is from biofilms that are produced by protozoa, and then the biofilms get contaminated with microbes, but your body can't clear it because the biofilms are a physical barrier to the immune system. So we're now realizing and appreciating the role of biofilms. If you search PubMed, there have been 25,000 publications on biofilms since 1975. But if you search for biofilm and Lyme, there have been 8 publications in just the last couple of years. So there's a massive awareness of biofilm problems, but clinically, no one really looks at it. We started a biofilm lab in January of 2014, and we've now measured 400, 500 specimens, and I can tell you the biofilms are a big problem, and they are directly responsible for many symptoms, and they harbor microbes. So all of the talks we have about all these different specific germs are still incomplete because you have biofilms in the picture. Biofilms, an example of biofilm is the thrombus layer that lines the blood vessel, which then causes inflammation and can lead to arteriosclerosis. So even arteriosclerosis is now being recognized as a chronic infection. And many chronic illnesses we're realizing have an underlying infectious cause. You know, maybe MS, maybe rheumatoid arthritis. So these are areas where people have always wondered, but now they're going back with better tools and searching again. People have misunderstood and confused symptoms with diagnosis. So when you call something fibromyalgia, it's just a set of symptoms. It's not a diagnosis. If you call something chronic fatigue, it's only a set of symptoms. It's not a diagnosis. In fact, there's very few things in medicine where the name of the disease is actually a diagnosis. And by that I mean that a diagnosis is actually identifying the root cause. So no matter what you call it, you have to realize that everything we do in medicine is a classification system. To try to understand things, we classify. And we may classify, and all of our classifications have to be considered temporary until we find a root cause. So when you're a sick patient and you get a label of, say, fibromyalgia, you have to ask yourself, what causes fibromyalgia? And then, so there are researchers that look at describing fibromyalgia better, and then there's research that might seek to find underlying causes of fibromyalgia. And so when you get to a root cause, you have a chance of actually being able to reverse. And so most physicians will just label it and they'll just do whatever the guidelines say for that set of symptoms, which is a classification, not a diagnosis of a root cause. And then they've done what they feel was medically prudent, and they've satisfied the lawyers and the policymakers, and they can go home and sleep that night. But some of us can't do that unless we fix the problem. We don't sleep well at night if we have a patient who's ill and we haven't found the cause. And some of us who try to do that have to look hard, and this is where you end up doing things that are not in the guidelines because you're exploring new possibilities. And if you're trained as a medical scientist, then you just naturally do that. And once you learn that method, they can't take it out of you. But this is where sometimes the regulatory agencies and the policymakers have had problems with practitioners because they're trying to limit what they do to try to regulate, control, and reduce costs. So they're practicing statistics on individual patients. That's what they want done. But if you're an individual physician trying to solve a problem for a patient, you have to take a personalized approach, and you can't apply epidemiology and statistics to the patients, to every patient. The policymakers are always thinking, they have to think in broad terms, but the practitioners are trying to treat individual patients. So there's this constant tension between the broad approach versus solving an individual case one at a time. And we were trained to trust our own evaluations more than anything else, more than the lab data. But the auditors and the policymakers just want to audit you with the lab data because that's the easiest thing for them to do. So in a way, the doctors in the front line are responsible for taking care of the patient, but the policymakers are forgetting that they're responsible for doing the research to help those doctors take care of the patients. So in my opinion, some of them are forgetting their real mission. But they do it because they think that they're doing the right thing and that they're trying to protect the public and keep the costs down and limit the use of anything that is not fully validated. But for it to be fully validated in a paper, it could take 17 to 21 years. And if you're a sick patient, their approach is, it's too bad. You didn't live at the right time.